So Bismillahirrahmanirrahim. Today we are going to take up the development of skeletal system. This is a continuation of your embryology of musculoskeletal system. We have done with the development of muscular system. Now we are going to take up the development of skeletal system. So we are going to take up and start with the development of skeletal system. You know there are two types of skeleton in the human body. First, you have the axial skeleton and you have an appendicular skeleton. Axial skeleton includes your skull, your rib cage, including the sternum and the ribs, and your vertebral column. While the appendicular skeleton includes your limb bones, upper limb and lower limb bones, and shoulder and pelvic girdle. What are the sources which contribute towards the formation of bones in these skeletons? First of all, the main contributor is the paraxial mesoderm. Mesoderm, you know, it is the middle layer of the three-germ layer, ectoderm, endoderm, and the mesoderm. Mesoderm was the middle layer. Mesoderm has three components, the paraxial, intermediate, and lateral plate mesoderm. Paraxial mesoderm is going to form somites and it is going to contribute, it is the main contributor towards the bone and cartilage. While lateral plate mesoderm is going to contribute towards the bone and cartilage in your upper and lower limbs. And there is some contribution from the neural crest cells towards the skeleton of the face. Head and neck may you have contribution from the neural crest cells. So these are the three main contributors. You must remember them. So this is an overview and a revision of your previous topics. You have done that in the third week. You have three layers: the ectoderm, the upper layer; mesoderm, the middle layer; and the endoderm. Mesoderm lying close to the on both sides of the developing notochord. The mesoderm is going to form paraxial mesoderm, a small component intermediate mesoderm, and lateral plate mesoderm. This paraxial mesoderm is going to differentiate into a structure, a donut-like structure called somite. And somite further is going to have three components which we are going to take up. And then you have intermediate mesoderm, which is going to form the kidneys, and you have the lateral plate mesoderm. Lateral plate mesoderm is going to contribute towards the formation of your limbs. So this is the developing neural tube. Neural tube, you can see the notochord and the mesoderm, ectoderm and endoderm below, and mesoderm in the middle. Mesoderm is forming your paraxial mesoderm. This paraxial mesoderm is going to form a structure known as somite. It is a donut-shaped structure. The dorsomedial part of the somite, it loses its epithelial character and becomes mesenchymal. These mesenchymal cells, they form your sclerotome. This is the main contributor towards the development of your skeletal system, sclerotomic part of the somite. And then you have dermatomic part of the somite. It is going to form the dermis or skin of the back. And then you have a myotomic component of the somite, the dorsomedial and the ventrolateral limb. These are going to contribute towards the formation of your muscular system. We did these in the last lecture. So today we are concerned with this part, sclerotomic part. This is going to contribute towards your skeletal system. So by the end of the fourth week, the sclerotomic cells become polymorphous and form a loosely organized tissue. This is known as the mesenchymal tissue. And as you know, mesenchymal tissue has the ability to form different cells. It can differentiate into fibroblast, osteoblast, chondrocytes. So here in the sclerotomic region, these mesenchymal cells, they differentiate into osteoblast, contributing towards the bone formation, and chondrocytes contributing towards the cartilage formation. So how many different types of ossifications are there? Ossification is the formation of bones. And we did in the general anatomy lecture that bones formed by two ways of ossification. One is the intramembranous ossification and other one is the endochondral ossification. Intramembranous. What do you mean by intramembranous? In intramembranous ossification, the mesenchymal cells, they organize to form membranes, and these membranes directly ossify to form bones. While in endochondral ossification, there is a mid procedure. First, the mesenchyme forms the cartilaginous model, the chondral models. These chondral models are then going to ossify and form bones. So in intramembranous ossification, mesenchyme is directly ossifying into bones, while in endochondral ossification, mesenchyme first form cartilages, then these cartilages ossify to form bones. So it has a three-step endochondral ossification has three-step procedure, while intramembranous is a direct procedure. Membranes directly ossifying into bones. So the faster one obviously is the intramembranous ossification. So a commonly asked question is why there is a need of intramembranous ossification. It is a faster and a quicker process. So it is needed where you need a quick protection. For example, in the developing brain, you need the brain tissue to be protected. So the most of the skull bones, they ossify from intramembranous ossification. While the base of the brain that ossifies from endochondral ossification, limb bones are formed slowly, so they also ossify by endochondral ossification. So we are going to take up the development of axial skeleton first, and in axial skeleton, first of all, we are going to discuss the development of skull. How is the skull formed? Skull has two components, the neurocranium and the viscerocranium. Cranium is the term used for skull, cranium. So the cranium has two components, neurocranium and viscerocranium. Neuro is for brain. So neurocranium includes the bones. Neurocranium includes the bones that cover and enclose your brain. Neurocranium, bones that form the cranial vault and they enclose your brain tissue. While viscerocranium are the bones that form your facial skeleton. They form your face. Neurocranium has two components. It ossifies from membranous part as well and has endochondral contribution as well. It has the membranous neurocranium. These form, most of the vault of the skull is formed by the membranous neurocranium. While base of the brain, the base of the skull bone is formed by cartilaginous neurocranium. So the neurocranium has two components, the membranous part, membranous neurocranium, and the cartilaginous part, which basically forms the base of the skull. It is known as chondrocranium. Cranium for the skull and the chondro means cartilage. Membranous neurocranium, it includes the bones, these bones, frontal bones, okay, and the squamous bone, while the membranous neurocranium, it gets contribution from two sources, the neural crest cells and the paraxial mesoderm. Neural crest cells are going to form this structure, the frontal bone and the squamous part of the temporal bone, while the paraxial mesoderm is going to contribute towards your parietal bone and your occipital bone. So membranous neurocranium, it gets contribution from two sources, the neural crest cells and the paraxial mesoderm. Neural crest cells is going to form your frontal bone, while the paraxial mesoderm is going to form your parietal bone and occipital bone. And you know these skull bones, frontal, parietal, occipital, temporals on the sides, where they meet, there are few sutures. Sutures, you can say these are the joints where the two bones are going to meet. Intramembranous ossification in these bones, in the frontal, parietal, and occipital bones, membranes, mesenchyme differentiates and forms flat membranes, and these membranes are directly going to ossify and form bones, frontal, parietal, and occipital bones. While these membranes are differentiating into bones, you can see bony spicules in these bones. You can see these bony spicules in the developing bones, and these bones are going to directly ossify, membranes are going to directly ossify into bones. So this is known as intramembranous ossification. A newborn skull. A newborn skull has sutures and fontanelles. What are sutures and what are fontanelles? Sutures are the places where the two bones are going to meet. For example, this is frontal bone, parietal bone, and occipital bone. Where the two frontal bones are going to meet, there is a suture. Where frontal bone meets parietal bones, there are sutures. Sutures are joints. And where two parietal bones are meeting, there is a suture. And where parietal bone meets the occipital bone, you have a suture again. So where the two frontal bone meets the parietal bone, you have a coronal suture. Coronal is a term used for where you wear a crown or coronal. So where the two parietal bone meets, there is a serrated suture known as sagittal sutures. You have done these sutures in the general anatomy lecture. And where the parietal bone meets the occipital bone, you have a lambdoid suture. So these are the sutures. Sutures are the joints or the places where the two bones are going to meet. And what are fontanelles? Fontanelles are large wide gaps between these bones, developing bones. And what is the function of these fontanelles, which we are going to discuss? Fontanelles are wide gaps and they are filled with seams of connective tissue. You can see this blue is a connective tissue. The developing bone, plates of bones and the connective tissue. Blue is the connective tissue. So there is one interior fontanelle. It is diamond shaped. It is located between the frontal and the parietal bones. These are two frontal bones and these are two parietal bones. And you can see this is the interior fontanelle. It is diamond in shape. And where the two parietal bone meets the occipital bone, you have a posterior fontanelle. Posterior fontanelle is triangular in shape. And then you have two anterolateral fontanelles, the sphenoidal fontanelles on both sides of the skull, and two posterolateral fontanelles, the mastoidal fontanelles on both sides of the skull. So 4 of these and 1 and 2, 6 fontanelles in the newborn skull. Why is there a need of these fontanelles and these sutures? These sutures and fontanelles, they help in the molding of the skull during the birth of the baby from the birth canal. These skull bones overlap and help in the easy delivery of the baby through the mother's birth canal. And these sutures and fontanelles, they help in the postnatal growth of the brain. You know, when these bones are developing, the brain is small. The brain is going to develop, the brain is going to increase in size. So if these sutures are closed, the brain will not have space to grow. So these spaces are left for the growth of the brain. Brain can grow. And you can know that, you must know that if these sutures close early, so the brain growth is going to get depressed. The child is going to have neurological symptoms as well. Is going to have a delayed neurological features. And these sutures and fontanelles help in the assessment of intracranial pressure and in the assessment of dehydration as well. If the intracranial pressure is raised, the sutures and fontanelles are going to burst out. They are going to protrude out. And when there is dehydration, severe dehydration in the child, these fontanelles are going to get depressed. So the clinician can see a newborn child with these fontanelles protruding outwards. He is going to see that maybe the child is having some raised intracranial pressure, and when these fontanelles are depressed, the physician can go towards that the patient, the child must be having some kind of dehydration. He must be losing water. And so you must know that the interior fontanelle, the normal closure of this interior fontanelle takes place by 18 months of age, while the posterior fontanelle closes by 1 to 2 months of age. This is highlighted because they're commonly coming in your MCQs, and the importance of suture. This diagram shows the process of the fetal head molding. When the head is going to pass through the birth canal of the mother, these bones are going to overlap and help in the easy delivery of the baby. Now we have discussed the membranous neurocranium. Now we are going to take up cartilaginous neurocranium, the part which is also known as chondrocranium. Chondro is for cartilage and cranium is for the skull. Chondrocranium basically includes the base of the skull. It is divided into 2 parts, the precaudal chondrocranium and the caudal chondrocranium. The precaudal chondrocranium lies in front of the notochord at the level of the pituitary gland in the sella turcica. This is pituitary fossa. It is also known as sella turcica. It holds your pituitary gland, the master gland. The part of the skull, base of the skull, in front of it is called precaudal chondrocranium, and it is derived from the neural crest cells. It includes your ethmoid bones, the lesser wing of the sphenoid and the greater wing of the sphenoid. While the part that lies behind this pituitary fossa, it is known as caudal chondrocranium, and it receives contribution from the paraxial mesoderm. It includes the body of the sphenoid, part of the greater wing, and Peter's part of the temporal bone, base of the occipital bone. So this is known as the caudal chondrocranium. Next, you have viscerocranium. Viscerocranium are the bones that form your facial skeleton. Bones of the face receive contribution from the pharyngeal arches. Basically, your first pharyngeal arch and the second pharyngeal arch. First pharyngeal arch has 2 components, the maxillary process and the mandibular process. Maxillary process is going to form maxilla, zygomatic bone, and squamous part of the temporal bone. While the mandibular process is going to form, as the name indicates, it's going to form mandible and 2 ear ossicle bones, incus and malleus. While the second arch is going to contribute towards the 3rd ear ossicle stapes, and it is going to form a needle-like bone, the styloid process. Ear bones are the first bones to fully ossify in the newborn. And the face also receives contribution from the neural crest cells. Neural crest cells are going to form your lacrimal bone, nasal bone. So the facial skeleton, the viscerocranium, is going to get contribution from the pharyngeal arches and from the neural crest cells. Pharyngeal arches, the first pharyngeal arch forms your maxilla, your zygomatic bone, and your mandibular bone, and incus and malleus of the ear ossicle. The second arch forms stapes and styloid process. Third arch is going to contribute towards the hyoid bone, thyroid cartilage. Fourth is going to thyroid cartilage and your cricoid cartilage. Now, how is a fetal skeleton different from an adult skeleton? You see, small face and large skull, and it is proportionate. So, what are the features of a fetal skeleton, and how it is different from an adult skeleton? Facial skeleton in an adult is 1/3. The facial skeleton is 1/3 of the skull, but in a newborn, the facial skeleton is only 1/8 of the whole skull. Why? What are the reasons for this small size of the face? This is because the paranasal sinuses are not well developed. Maxillary sinus, sphenoidal sinuses are not well developed. There are absence of teeth, and the size of the bones is small. While in the adult, you have the nasal sinuses, paranasal sinuses are well developed. You have eruption of teeth and large size of the skull. Now we're going to take up some important clinical correlates relating to the development of your skull. Cranioschisis. Schisis mean opened. So cranioschisis, when the cranial wall fails to develop. The cranial skull bones are not well developed and the brain is lying exposed. Brain is lying exposed. Brain is exposed to the toxic effects of the amniotic fluid and it is going to degenerate. This is also known as anencephaly when the brain tissue is not present. So you can see this child with failure of the cranial bones to form, the brain tissue is exposed. It is exposed to the toxic effects of the amniotic fluid. It is going to degenerate and these babies hardly survive. They're born dead. While cranium bifidum, when there are small gaps left in the ossification, the cranial bones are not well ossified. Small part of meninges can protrude out. Along with meninges, the brain tissue can also protrude out. So this is meningoecele when the meninges are going to protrude out from the cranial defect. And if there is brain tissue along with meninges, it is known as meningoencephalocele. These defects, cranium bifidum, anencephaly, meningoencephalocele, meningoecele, these can be detected before the birth of the baby. By prenatal scan, ultrasound scan, and by aminosynthesis. In aminosynthesis, you have increased and raised alpha fetoprotein levels. So the mother is advised to either abort the baby if there is anencephaly, no brain tissue formed, and before conceiving, the mother is advised to take folic acid. Folic acid helps preventing these defects. What is craniosynostosis? Craniosynostosis is the premature closure of one or more sutures. We have just studied that sutures and fontanelle help in the growth of the brain. And they are left and they close by anterior fontanelle closed by 18 months and the posterior 1 to 2 months of age. But what if they are closed before their determined age? This is known as craniosynostosis, premature closure of the sutures. It can be one suture, more suture. These premature closure can be genetically determined, or they can be due to the deficiencies in the calcium and the vitamin D deficiency in the mother. Scaphosphely is the early closure of sagittal suture. The sagittal suture close early. There is frontal bossing and long tower-like skull. This is known as scaphosphely. These are the deformities of your skull. Scaphosphely, early closure of the sagittal bone resulting in frontal bossing, long tower and narrow skull. Then you have brachycephaly. Brachycephaly is the early closure of the coronal suture between frontal and the parietal bone, the coronal suture. It results in a small size skull. And then clegocephaly. Clegocephaly, flattened skull from one side, deformed skull. It results when there is premature closure of coronal suture on one side. One side there is premature closure and other side there is a normal closure. So it results in a deformed skull, plagiocephaly. Cloverleaf skull or cleavage skull, there is mutation in the fibroblast growth factor receptor 3. This results when two or more sutures are prematurely closed. It can include your sagittal suture, parietal suture, your sagittal suture, your lambdoid suture, and the skull is deformed. It looks like a clover leaf. This is a clover leaf. It is commonly found in Ireland, this shaped leaf. So the skull resembles a clover leaf. It results from mutation in the fibroblast growth factor receptor 3 and premature closure of sagittal suture, lambdoid suture, and coronal sutures. Microcephaly. Micro means small, cephaly means skull, and this is a microcephaly results when there is a small size skull. It results from the alcohol abuse in the mother. When the mother is expecting and she's taking alcohol as well, this is going to result in this deformity. The child is mentally retarded as well because there is the growth of the brain is restricted. Cleidocranial dysostosis. Cleido means clavicle, cranial means skull, and dysostosis, deformed or ossification. So there is the clavicles are absent in this child, and there are the defects in the closure of the sutures as well. Delayed closure, there is frontal bossing. The child may be, the cleidocranial dysostosis may result when there is vitamin D deficiency, calcium deficiency, and delayed closure of the sutures. So you can see absence of clavicles and frontal bossing in this child. Cleidocranial dysostosis. Now we have done with the skull. Now we are going to take up development of sternum. It is also a part of your axial skeleton. Sternum, the breastbone, you know, it has three parts: manubrium sternum, body of the sternum, and xiphoid process. So sternum develops from the parietal layer of lateral plate mesoderm. It develops in the ventral body wall, front of the body wall, and from the parietal layer of lateral plate mesoderm. Two sternal bands are formed. These two sternal mesenchymal bands are formed. These mesenchymal bands undergo chondrification, and by endochondral ossification, the chondrocytes are going to ossify and form your bones. So two mesenchymal bands known as the sternal bands are going to form. In these mesenchymal condensations are going to occur, and then chondrification is going to occur. Chondrocyte centers are going to appear. These chondrification centers are later going to ossify and give you your sternum bone. And it is going to have manubrium sternum, body of the sternum, and xiphoid process. Xiphoid process is the one that is going to ossify at the last, by 40 years of age. And how are ribs developed? Ribs lie along sides of your sternums. Ribs have two components, bony component and the costal cartilages. The bony component of each rib is derived from the scleroderm cells in the paraxial mesoderm, while the costal cartilages arise from the sclerodermal cells that migrate across the lateral somatic frontier in the lateral plate mesoderm. We just did yesterday what is the lateral somatic frontier. It was a border between the developing somite and the lateral plate mesoderm. The sclerodermic cells which cross this border, they are going to contribute towards the costal cartilages, while the paraxial mesoderm which retained on the other side of this frontier, they are going to contribute towards the bony part of each rib, and it is going to form in the thoracic region, ribs. Some important clinical correlates relating to the ribs and sternum. Ribs have two important clinical correlates are the accessory ribs and the cervical rib. Accessory ribs mean an increase in the number of the rib, and mainly they are found in your cervical region. Cervical ribs can impinge on your brachial plexus as well as on your subclavian vessels, and this can result in the vasomotor changes in the upper limb and the neurologic changes in the upper limb. So there can be other deformities in the ribs as well. Ribs can be deformed in shape, forked. You see forked rib. There can be increase in the number of the rib. Accessory rib mostly found in your cervical region, known as cervical rib. This rib is going to impinge on the brachial plexus as well as subclavian vessels. Then you have cleft sternum, a deformity of the sternum. The sternal bands do not fuse properly. There is a wide cleft or space left between the two sternal bands, and in this the heart is exposed. This you can see cleft in the sternum of this child. This cleft can be surgically treated by wiring these two sternal bands. And two other deformities, very important deformities of the sternum, pectus excavatum and pectus carinatum. In pectus excavatum, excavation means digging. So there is a large, you see, a concavity between the thorax, and this is a concavity in the sternum. The sternum is depressed. It is known as pectus excavatum. It can be due to the mineral deficiency in the child, growing child. And pectus carinatum. Carinatum is resembles the keel bone of the chicken. You know, the breastbone of the chicken. This is pointed. The sternum is pointed and resembles the keel of a chicken. This is known as pectus carinatum.